Hi, Dan. Welcome to India, New Delhi. And this is a meeting, Dan, regarding the Delhi Ophthalmological Society, which is the largest society, state society in this country, more than 10,000 members. And today we are fortunate that you accepted our invitation to talk about presbyopic surgical correction. You all know Dan Reisnan is a pioneer in refractive surgery world over, and he has so many publications, teaching, clinical experience in various refractive surgeries, and we all follow his norms, regulations. And today it will be a pleasure to listen to him. Dan, all yours. You can present your talk today.
Thank you. Actually, I was really enjoying listening to Akesh's talk, so I'm sorry you cut him off. Right, let me share my screen for you here. It's a beautiful fresh morning here in London, or as the Germans say, visible. Okay, so you've asked me to speak about the surgical management of presbyopia. And obviously, many of you know that I developed a procedure called Presbyon many years ago, which is now commercialized by Carl Zeiss, so I have a financial interest in that. My other financial interests, which are to do with epithelial mapping and diagnostics, are not really relevant to this talk. So, the eternal discussion, the argument is that, you should correct it on the cornea or you should correct it on the lens. And this debate, they're almost like two separate planets and people not really able to communicate. And this debate has been going on for 20 years. And it's funny to me because I've actually looked at it another way, and I've thought that this is not about two completely separate planets at all. It's actually about three planets. And the three planets are multifocal optics, using spherical aberration to increase depth of field, and monovision. Those are the three planets. And it's just a reclassification of the argument. Everyone has been aware of multifocal IOLs and multifocal corneas with little inlays and multifocal corneas by ablation. Everyone's been aware of contact lens monovision, IOL monovision, obviously LASIK monovision. What I think is the area that people are less aware of is extended depth of field using spherical aberration. And the first real procedure to do this was this, what I called laser blended vision in 2004 when we started developing it. And this is not monovision. This is actually a modification of binocular vision. And stereo acuity is maintained and binocularity is maintained. So it is in the middle of these two. And of course, we now know that there are a number of IOLs in the world, whatever, 15 years later, that are coming onto the market that are based on these principles of modifying depth of field using spherical aberration. So just briefly, let's go over multifocality. And I mean, I don't have to belabor this because this has been the topic of 60, 70% of the airtime at all of the big meetings. Damien Gatinel published a beautiful paper showing the different kinds of lens that have bifocality or trifocality or EDOF. And here's what was called an EDOF lens in 2014. It came out at the London ESCRS, the Symphony. The company was saying that this is not a multifocal lens, it's an EDOF lens. And when you put this lens through Osiris, which has an extraordinary resolution, there you find that, of course, it's a diffractive IOL, and it does cause night vision disturbances, and it does cause the same effects as other multifocals, reducing contrast. So there's no free lunch on splitting light. On the cornea, we have a very beautiful, scientifically, progressed clinical experiment in the marketplace where a multifocal cornea with a central island of 2 diopters resulted in 12% of patients losing 2 lines. With the same system, they reduced the ad, made one eye a little bit more myopic, and increased the safety to only 5% of eyes losing 2 lines, which of course isn't satisfactory because that's the same as a Vizix 2020B in 1995. So they went and reduced the ad even further in the dominant eye so that binocularly there was no loss of lines, but obviously monocularly there probably was. So multifocality in the cornea has the same disadvantages of multifocality in an IOL. And so we know that there's a high chance of night vision changes, reduced contrast. Some patients are not going to adapt. And of course, if in an IOL situation, what are you going to do for an enhancement? Because you're obviously going to do laser, in which case, why didn't you start with laser? So let's go to the monovision side. And again, I'm just reviewing this. Everyone knows that one eye is set for distance, one eye is set for near, and that unfortunately in monovision, the intermediate doesn't work because of the amount of ad required for near vision. Now, those are the challenges, right? Intermediate vision loss, actual neural subtraction because of the confusion between the eyes or in the brain, loss of stereo acuity, loss of the fact that you've got summation when you have good binocularity, and that only 50–60% of patients tolerate it. The thing is that if you reduce the monovision, as Graham Barrett called monist monovision, yes, you improve on all of these challenges, but then you don't get the intermediate vision. The Pardon study in 1990 is really a critical study to understand. What we have here is the amount of anisometropia along the x-axis and the summation in the vision. So if you have binocularly 20/20 vision in both eyes, you will have monocularly, binocularly, you'll see 20/16 or 20/12 because of the summation. That summation decreases, but then it increases once suppression occurs, because obviously if there's suppression, you don't get neural subtraction. And neural subtraction is what's called cross-blur and discomfort and asthenopia. But we lose the summation loss, and we only have the vision of the single eye when we don't have both eyes. So understanding that curve is important, and understanding that it is well understood that if the anisometropia is more than 1.5 diopters, then you don't get stereo acuity, and actually you can break the stereo acuity and you may never get it back, even if you stop the monovision. So in the end, monovision also has these compromises, which is that not everyone tolerates it, and also that you have to kind of choose between intermediate or distance vision. And so now we come to what is the industry's, like everybody has converged on the same solution of using spherical aberration as the aberration that is best tolerated to increase depth of field. And why is this? It's because spherical aberration is a natural aberration. It occurs in the lens. It increases with age. Obviously, when the lens becomes rounder, when you accommodate, there's more spherical aberration, so it increases depth of field. This is something which, is built into the system, right? And it is not multifocal. It is not more than one focus in the same eye. So perfectly focused systems, yeah, the aspheric lenses and no aberrations and no spherical aberration, but then the depth of field is very, very short. Whereas if you disseminate the focal point by spherical aberration somewhat, you actually get increased depth of field. This is an exact replica, sort of an experiment, I should say, of showing you what defocus does. And you're all in the audience looking at this, and you can see that at -150, your vision's 2200. You can't see letters. Whereas the same defocus with spherical aberration means that you in the audience are looking at this, you can detect those edges now. And that's because the brain has filters for spherical aberration. And so once you've looked at this this is the image on the retina, that is with the added spherical aberration on a plano eye and a -150 eye. But because it's in your brain, the vision in the brain in each eye is actually much better. And the brain is putting together two very similar images once the neural processing has occurred. And that is quite different from putting together two images that your brain can't process. And that's monovision. So when we started describing this, the labs around the world that had adaptive optics systems were starting to check, experimentally, if you put spherical aberration in front of the eye, how does the depth of field change? So it's non-surgically. And very elegant study by Carolina Rocha, where she showed that increasing spherical aberration, both in the positive spherical aberration and the negative spherical aberration directions, increased depth of field. And you can see that they were getting about 1.5 diopters of depth of field. And there was a zone where you get a linear increase in depth of field from the amount of spherical aberration induced. But if you go beyond that amount, it becomes toxic. And we showed this in our very first publication, which was to do with fixing night vision disturbances and finding that if we reduce the spherical aberration to a 0.6 level, contrast sensitivity recovered. Whereas, if it was above that, then the patient suffered with night vision disturbances. So everyone's understanding this theoretically. And in our case, we realized that we couldn't change the depth of field more than 1.5 diopters before getting into the toxic range, losing contrast. And so we needed to use a little bit of anisometropia to get the near and the distance all together. And this creates effectively a blend zone, because the distance eye has a depth of field of 1.5 diopters, which at the near end extends to -0.75, and the non-dominant eye, which is set to nominally to -150, at distance, it has a vision as if the eye was -0.75 also, but at near, it has vision as if it's -225. So that's the center and that's the center. So the blend zone is because both eyes have similar acuity, and it's 0.75, which is sufficient to identify edges and fuse the two images from the two eyes. So all of these monovision challenges are actually eliminated by adding spherical aberration to a -150 defocus. And this is not the same as modest monovision. It's not monovision. It's binocular vision, because both eyes have sufficient information that the brain can put the two eyes together. And so that means that this picture of having intermediate blur and very poor distance in the non-dominant eye means better distance in the non-dominant eye, excellent intermediate vision and near, and distance vision, better distance vision in the non-dominant eye. So it's in the dominant eye, sorry. So I'm showing you here how there is neural summation. You'd expect a -150 eye to see 2100, but actually 80% of our eyes are seeing 2060. And this is 395 patients, emmetropes, hyperopes, and myopes. And you can see that overall, 92% of them were seeing 20/20 in the distance eye. And this went up to 96% binocularly. In other words, the blurred 20/60 eye is giving more summation and giving better distance vision in the brain, summation. And we've also demonstrated that stereoacuity is maintained, that we have at least 3/4 of the patients with at least 100 seconds of stereo, and all of the patients with 400 seconds of stereo. You only need 800 seconds of stereo to thread a needle. So we're maintaining stereoacuity, proof that this is binocular vision. And so the question then is, well, how do you do this? Well, the answer is you have a software that you push a button on, and you do LASIK. It's incredibly simple. How do you qualify the patients? Well, basically 97% of patients pass the tolerance test that we devised that takes 2 or 3 minutes. So it's a 2 to 3 minute test on the chair. And then you just do LASIK with a software that calculates everything in the background. And you end up with these results, which I've presented a million times. These are our own papers with over 100 patients with 1-year follow-up, showing levels of vision that you could never expect from intraocular lens calculations. Maybe you certainly expect it from a light adjustable lens, but not from any AI or whatever you're going to use to do lens calculations, because the ELP is such a messy subject. But incredible amounts of patient visual independence with no loss of lines, no loss of contrast. And around the world, everyone's starting to publish this now. There are apparently, according to Zeiss, over 320,000 of these have been done in 250 centers. So it's not widespread, but it is out there. And we have this beautiful publication by Sheetal Bra and Sri Ganesh, where they showed that the amount of patient satisfaction is huge, but look at the spectacle independence. It's nearly 100%. And the dysphotopsia rates is nearly 0. The same thing again from Andrea Russo in Italy. Huge patient satisfaction. Well, that's easy to get because you under-promise, you over-deliver, you're fine. But again, massive independence from glasses, something that's way more than you would expect with multifocal optics, and incredibly low dysphotopsia rates. And that's because there's no loss of contrast. So in the end, and maybe this table is biased, but if you look at these criteria and you look at the disadvantages of each methodology of correcting presbyopia, either multifocality, monovision, or spherical aberration with extended depth of field, it's clear that we have the least disadvantages with the center option. And so, yes, these IOLs now with extended depth of field are coming out, and spherical aberration being used to increase depth of field. So then the question then is, well, can you do it? What should you do? Should you do it with an IOL or on the cornea? And the answer is, it's easy to decide that if you look and measure lens transmission, because obviously a patient who has a cataract and you put a multifocal in is going to be super happy because you're increasing the transmission. But somebody who has good lens transmission and you decrease their transmission to 85%, which is the best trifocals out there, maybe it's, there's a chance that they're not going to like that change. So this idea of treating these two patient groups in the same way, it can be a problem. So when we look at actual cataract and, this gray zone of 60 to 70, in Europe, we get cataracts way, way later than you do in India. But if we just look at the younger presbyopes, so we're not arguing about the other stuff, the younger presbyopes, remember that 30% of people in Europe develop cataract, not everyone. And so a lot of people die without having had cataract surgery. So the excuse of doing the lens surgery just because you might get a cataract is not great. And remember that in Europe, 1 in 6 patients develop macular changes. So you can have a normal OCT at the age of 50 and develop, severe macular changes, and you have a multifocal in your eye. Not a great situation. Also, of course, intraocular surgery invites the possibility of the more catastrophic complications. And we know that retinal detachment rates are much higher in people in their 50s having phaco than people in their 80s, 4 or 5, even 20 times in one study. We also know that a corneal astigmatism is relatively stable until we're 40. And then from 40 to 80, it continues to change. We know that from large studies. Here's a study of for 4,000 eyes showing that 1/3 of eyes change by 1 diopter of CIL in 5 years after the age of 40. So the idea that an IOL surgery is permanent vision is not true. It's permanent lens replacement, but it's not permanent vision. We go over this lecture of 15, 20 minutes in about 8 hours when we teach this formally. And when we started teaching it, we found that surgeons sitting in the audience were starting to ask to have it done on their own eyes. And so it was an interesting experience for me, because 10 years of talking about this on stage in short talks, and then setting up a course where we talk for a whole day about all the scientific background of it, bought a pair of glasses. I never owned a pair of glasses. And I went directly to surgery. And I now, see like I did when I was a kid. And my refraction is minus 175 in my non-dominant eye, but I still see 20/50 in that eye, which is why I have, my superb distance, intermediate, and near vision. But I also have 40 seconds of stereo, and my contrast is still very, very high. So that's me at Club Med when I was 20 years old, and I might not look the same, but I certainly can see the same. So overall, when we look at the different approaches to presbyopic correction, we see that the least disadvantages are obtained by spherical aberration, increasing depth of field. And whether you do this on the cornea or lens should depend on the health of the eye, the amount of cataract, and the fact that laser refractive surgery is enhanced as many times as you want over a lifetime. And that once you got that spherical aberration in the cornea, then you can use a monofocal, high quality, low PCO rate IOL and not a premium diffractive lens to correct the cataract later and still maintain the benefits of the EDOF on the cornea. So thank you very much for your attention.